Hello, welcome everyone. Sorry we're a couple minutes late. We're just having a little technical difficulty having our moderator join, but we're going to proceed in his absence. So greetings, my name is Laura Ghiron. I'm a member of the ExpandNet Secretariat and a co-chair of the Health Technical Working Group that's hosting today's session. I'm also a member of the Executive Committee of the Community of Practice on Scaling Up Development Outcomes, and I'm warmly welcoming everybody to this last working group organized session of our 7th annual workshop. The COP now has more than 2,500 members, representing 400 organizations in over 60 countries, and it's growing every day. A few words about the COP for people who may not know. Participation is in the COP and all of its working groups is voluntary and it's free and everybody is welcome. Our goal is to professionalize the practice of scaling and to encourage learning across sectors, across geographies and perspectives. In addition to this virtual annual workshop, the COP issues quarterly newsletters and periodic thought pieces, all of which can be found on the COP's website. And Natalie or Gabby are going to pop the website into the chat, and I hope that we'll use this chat during the proceedings because we like to keep it an active workspace. So in addition to the health working group, there are 8 other working groups that explore scaling through the lens of different sectors, different thematic areas. And so I want to encourage everyone to join those, and that's all accessible through the COP website. I also want to extend a special welcome to those who may be new to the COP or to our working group. And we hope that you'll continue to engage with us around our shared commitment to scaling public health and development interventions. I'm sorry about all the beeping. I thought that I had silence on. In any case, I want to tell you a little bit that the health working group, of which I'm co-chair, is intentionally trying to bring together professionals across the global health spectrum with expertise in all different technical areas. And for that reason, I'm asking for everyone's help to continue growing and spreading the word about anyone who has a scale-minded approach and want to learn more, please join us. And so speaking of growing this network, I'm pleased to share that we recently were joined by a new co-chair for our working group, Dr. Mojisola Odeku, who works with the Program Advocacy and Communications team at the Bill and Melinda Gates Foundation in Seattle. Dr. Odeku continues to be based in Nigeria, where she's led an illustrious career working in the fields of family planning and maternal newborn child health and reproductive health, both for the Federal Ministry of Health and then a portfolio of work under the umbrella of NURI and the Challenge Initiative projects, which anyone who works in Nigeria probably is pretty familiar with in the public health space. Those efforts had a major focus on sustainable scale-up. And unfortunately, Dr. Odeku can't be with us today, but she will definitely be playing a key role in future webinars and activities. So because the technical work of ExpandNet members, of which I am part of the Secretariat, has mostly emphasized family planning, reproductive health, and maternal and child health, many of the health working group members are from those areas. And with today's webinar, we're seeking to widen this discourse to transcend the silos of our respective health areas and facilitate comparative learning and experience sharing around scaling up. So hopefully you've had a chance to participate in prior plenary and working group sessions. But if you missed them, I want to highlight that today's will be available and all the prior ones are available on YouTube, accessible through the COP's annual meeting page. And another housekeeping remarks is that the session is being recorded. If you want to save on bandwidth on your side, you can turn off the incoming video feed. You can use the Teams meeting window where there's 3 dots. You can look for that turn off incoming video option. We can use the chat box, as I said, to direct questions to panelists or our moderator if he's able to join directly. And we will have a section where we're posing those questions to our speakers in the last 10 minutes. So we definitely want your input for that. And now it's my pleasure to introduce our illustrious panel. We're trying something. Well, our goal, let me see if Lester's made it, not yet, but our goal today is to try something a little different. So if our moderator, Lester Coutinho, is able to come, he will be representing the family planning and reproductive health field's perspective on scaling up. And then our 3 other panelists come from different technical areas of health. So I think I'll introduce our panelists first. So Charles Holmes is the director of the Center of Innovation in Global Health and professor of medicine at Georgetown Medical School. He has had several leadership roles in the technical area of HIV/AIDS, including the chief medical officer and deputy U.S. Global AIDS coordinator for PEPFAR during the Obama administration. And prior to that, he served 4 years in Zambia, leading as CEO a staff of 1,000, working at the Center of Infectious Disease Research. Dr. Holmes continues in his advisory capacities with governments, multilateral organizations, and private sector for improving health system response to epidemics and performance optimization. We're very lucky to have Dr. Holmes with us, as are we super lucky to have Dr. Corine Karema, who's the interim CEO of the RBM Partnership to End Malaria. I think RBM refers to Rollback Malaria, but the name has changed. So Dr. Corine served as the director of the Rwanda National Malaria Control Program for 10 years, and during her career helped lead major scale-up work in malaria control strategies, policies, and research in efforts to reduce malaria morbidity and mortality. Corine has served several high-level scientific and advisory roles for WHO, the Rollback Malaria Network, the Global Fund for HIV, TB, and Malaria, and others. And she's currently teaching at the University of Global Health Equity while herself pursuing her doctorate at the Swiss Tropical and Public Health Institute in Basel, Switzerland. And our third speaker panelist, Dr. Jim Ricca, is the Director of Adaptive Management, Monitoring, Evaluation, and Learning for JPIGO, which is a US-based nonprofit. Jim works with the USAID-funded Momentum Country and Global Leadership Program funded by USAID, which focuses globally on maternal, newborn, and child health programming. Jim's a family doctor and public health specialist who brings extensive scale-up and knowledge management experience to his role with Momentum. Okay, so I want to, I'm going to serve as moderator in Lester's absence until hopefully he arrives. And so we're going to begin with our panelists providing a high-level overview of work in their technical areas. They'll provide some common approaches or frameworks that are used for scaling up and insight on the facilitators and barriers that are faced in their technical area. And then we will moderate a discussion among the panelists about how each of these technical areas addresses some of the major scale-up issues, including equity, intervention complexity, institutionalization, the need for speed, adaptive management, and more. Again, as they're speaking, please pose questions in the chat, and I would like to answer those in the last 10 minutes, and then we'll try to have some closing reflections, and then we'll let you go. So that's our session. So I guess I should probably also introduce Lester. Has he made it yet or not yet? Looks like not yet. So let me introduce him in case he shows up midstream. So Lester Coutinho is currently the Director of Innovation and Learning at DKT International, which is a Washington-based DC nonprofit NGO that brings the power of social marketing to some of the largest countries with the greatest needs for family planning, HIV prevention, and safe abortion. Prior to his work with DKT, Lester was the Deputy Director of Family Planning at the Bill and Melinda Gates Foundation, where he led the Country Action Initiative to address universal access to family planning. He's also worked with the Packard Foundation in India and other countries in South Asia. And Lester has multiple master's degrees in political science, philosophy, and sociology, and has conducted extensive anthropological research on public health issues. So I am looking forward to hopefully Lester arriving, but meanwhile, I would like to hand the microphone over to Dr. Charles Holmes, who will give us the high-level view on scaling up from the HIV sector. Over to you, Charles. Thank you.
Well, thanks so much, Laura, and it's really great to be with all of you and to have the opportunity to share some learnings bidirectionally with you, and just such a great diverse group of people that I see coming onto the call today. And I know how dedicated everyone is to improving health and well-being at scale. So it's really inspiring to learn more about this group. And apologies if some of you do have a similar background to mine. Some of this may seem repetitive for you, but please bear with. I just want to mention a few things that Laura asked us to outline, and just really thinking about the interventions that have most defined the field of the global HIV response over the last couple of decades. And I think there are really kind of three main areas. Of course, there are many technical areas, but really treatment of HIV infection with antiretroviral therapy, or with ARVs, as we say, as well as the prevention of HIV infection from mother to child during pregnancy, and prevention of infection amongst those who are at risk for sexual transmission of infection, as well as sort of the mitigation of some of the societal and personal effects of HIV, including care for children orphaned or otherwise made vulnerable by HIV, have really been kind of the centerpiece of the response in many ways. And of course, demand generation and community support needed for each of these really has also been a central component. And I think the balance of these has really shifted. We're celebrating now the 20-year anniversary of the President's Emergency Plan for AIDS Relief. In fact, in the next couple of days here, and a lot has shifted over the last 20 years, and sort of the balance between each of these. And just sort of as an example, as we've reached many of the people at greatest risk for death with life-saving treatments and been able to keep them on over the first decade, mitigation efforts have become, thankfully, slightly less prominent and needed. And as treatment has not only been shown to save lives, but also to provide prevention benefits up to 96% in terms of reducing onward transmission of infection, the emphasis on driving up coverage of treatment has become even more prominent. In fact, we now have a 95 goal at UNAIDS by 2025. We're trying to reach 95% of people so that they know their status, 95% of those individuals on treatment, and then 95% of them virologically suppressed on treatment. So a really critical goal, both for saving lives as well as prevention. But we've also unfortunately found that we're pretty severely off track with our goals for reducing new infections. And there's urgent attention to the further expansion of evidence-based prevention, from early behavioral intervention and condoms to the addition of voluntary medical male circumcision, as well as pre-exposure prophylaxis, pills that people can take to prevent acquisition of HIV, as well as partner notification and outreach services. Clinics have really been the prevailing site of delivery, especially obviously for treatments early on. But HIV moved, I think, progressively to include nurses as prescribers, and has evolved. And today, as we reach healthier and healthier people with long-term treatment and prevention options, the field's really moving towards community delivery strategies and PHC integration that we'll talk about. And we're trying to learn a lot from our family planning colleagues who have really gone that direction over the before HIV, and there's a lot we can learn. Just a few generalizations. Really, you know, we've moved from kind of this emergency approach that took what was considered a very complex intervention, that of delivering treatment with a lot of medications and monitoring, and approached it through a public health approach that focused on algorithmic care, limited laboratories, and a focus on the simplest pill regimens we could to get pills into people to save lives. It required a very verticalized supply chain for hundreds of millions of doses of ARVs, test kits, condoms, etc. And external funders have played a very large role that I'll talk about a little bit later, as well as normative bodies that have helped to determine what gets scaled and how in some cases. And I think there's also been increased attention to efficiency because funding, although high, has leveled off over the last decade. And so looking at cost per intervention and possibilities for integration have been critical. And when I think about a couple of the biggest sort of facilitators and barriers in our field, you know, I think in terms of facilitation, strong leadership from WHO working with member states has really been critical for ensuring that the best science and approaches get scaled with kind of minimal time for the diffusion of that innovation. I think that's been a hallmark of the field. Increasingly strong technical capacity that exists at the country level and NGO level locally is really quite impressive and has grown tremendously over the last 20 years. Civil society advocacy has been a huge facilitator of the success of the HIV response. It has waxed and waned over the years, but remains absolutely central to the further progress. And the magnitude of funding obviously has been a massive facilitator for aggressive scale up against this, you know, pandemic that we still have yet to fully beat. In terms of a couple of barriers, just to mention, I think that the HIV programs are facing opportunities for impact that we can't necessarily afford right now. And we're having to look at trade-offs between treating another person for HIV and then also ensuring that their other health needs, be it antihypertensives or diabetes drugs, etc., are taken care of, to look at the whole individual. And that's difficult for any particular disease response to handle. So we're really looking at leveraging private sector, PHC and UHC agendas, and national funding. I think there's also the growing challenge of structural drivers of infection in burgeoning populations of adolescent girls, young women, with intergenerational sex, economic power imbalances, limited economic opportunities, really leading to survival and transactional sex, as well as gender and sexual violence that you know have adverse health consequences and make it harder to end this HIV pandemic. So that's led to a lot of thinking about multi-sectoral interventions that promote education, empowerment, law enforcement interventions with law enforcement to help them be more supportive of a public health approach. Lastly, I just mentioned other marginalized populations who represent, in many cases, kind of the last 10, 15, 20% on the path to scale, yet they're really at risk for poor outcomes. They may be criminalized in various countries. Their care is often highly stigmatized, particularly for men who have sex with men, female sex workers, as I've just mentioned, as well as people who inject drugs. And, you know, we've turned to approaches such as peer-to-peer outreach, safe drop-in centers, and really lobbying for legislative change in hopes of overcoming some of those barriers. So that's a snapshot of the state of our field, and look forward to further discussion. Thanks, Laura.
Thank you, Charles. That was an incredible overview, rapid fire and incredibly rich. And I had probably 20 questions that came up already, but I don't want to do any of those now. But I do want to flag for everybody that we will pick up on several of the issues that Charles raised, but I encourage you to listen as you hear the other speakers, start drawing some comparative analysis, some thinking that from your own perspective, from your field, some drawing, learning that you're taking away. Now, let Dr. Corine have the floor and share some experience from malaria.
Thank you very much, Laura. Good morning, good evening, and good afternoon, everyone. And thank you very much for inviting me on behalf of the RBM partnership. So maybe I wanted first to tell you who we are. So the RBM partnership is a global platform for coordinated action against malaria. And of course, what we do, we mobilize action and resources and forge consensus among partners. We have more than 500 partners committed to end malaria. Of course, our vision is to get a world free from malaria, and then we have a strategic plan that have 3 strategic objectives, and one of them is really to facilitate the deployment and scale up of intervention techniques as well as a strategy. So in terms of malaria, as you know, malaria is still a public health problem, and maybe to just give a picture every year. So when we look at the World Malaria Reports last year, WHO estimated to have 214 million malaria cases and more than 600,000 deaths. And of course, 86% are children under 5. So you understand that, for instance, we have a child dying every minute from malaria. So this is how it's big, and it's a huge public health problem. So in terms of the intervention, as Charles said, for malaria, the WHO recommended intervention for reducing malaria-related morbidity and mortality includes diagnostics, treatments, of course, prevention with vector control, and then we also have chemo preventions for high-risk groups. So, for instance, as I mentioned, infants, children under 5, and then, of course, what is important for us, it's we also have pregnant women, that's a vulnerable group to malaria. So all the different malaria control intervention are implemented based on the malaria transmission setting. So for instance, we are having vector control interventions such as the distribution of mosquito, the long-lasting insecticide-treated nets, the mosquito net, as well as the distribution of the spraying of insecticides in the wall of houses. It depends on the malaria transmission. And then, of course, we also have the treatment. The treatment is for all age group. And we also have chemo prevention that are specific, first of all, based on the seasonal transmission. So it's really affected and distributed throughout the year, maybe before the raining season. And then you also have chemo prevention for pregnant women that are also given to pregnant women in the second and third trimester of their pregnancy. So most of the malaria control intervention I combine and influence based on the malaria transmission setting. So in terms of the scaling up, for instance, you will see that malaria is a disease for the poor. Malaria, it affects children under 5, and this is how, in terms of scaling up, we use different modalities of distribution. So for instance, for the mosquito net for pregnant women and children under 5, they've moved from distributing to the health center, but focusing to the antenatal clinics where pregnant women are coming for an antenatal consultation, she's also given a mosquito net. So that will also help us to increase the coverage of pregnant women who are using mosquito net. And this is the same for children under 5. Mosquito nets are distributed at the immunization clinic so that when they come for a vaccination, they also receive a mosquito net. So those are the modalities as well as the type of distribution that we do. On top of that, we have been moving from the health center, the primary health care, to the community, where we also do mass campaign. For instance, the seasonal malaria chemotherapy are given at the community throughout when there is a campaign, and this also has increased the coverage as well as the uptake of the drugs that are given for chemo prevention. And also we are also doing mass distribution of mosquito nets to reach and then the communities, and then also it's also done by community health workers. So in terms of also diagnostic and treatment, we have also expanded the community case management, where we are using community health workers who are able to test malaria using a rapid diagnostic test, and as well as treated those who are malaria positive. So this has also helped increasing access to diagnostic and treatment. So in terms of the facilitator, as I say, and I'm sure it's almost the same as Charles mentioned for HIV, the first one is the commitment, strong commitment and partnership. So we have a very good Malay community. Everyone is aligned in terms of all the technical as well as the control intervention. The second one is funding. So we for the last 2 decades, there is an increase of funding related to malaria. Of course, for the last 2-3 years, we saw that the funding is plateauing, but it's really showing that when you compare to previously, there is a really engagement as well as strong commitment for funders, donors. And then the third one, of course, it's improvement of the health system, which is helping at the distribution point and then the delivery of all malaria control intervention. So in terms of the challenges, first of all, we do have funds, but it's not enough. So one of the issues we are having is data. As I say, we need to have evidence of where to deploy the malaria control intervention. It's based on data. We need data to define the malaria transmission. We need data to define the high-risk group. And this is one of the challenges that we are having. And also, of course, one of the barriers is also the culture, behavior, especially in terms of the use of the mosquito net, as well as spraying the house. There are some communities that are not really okay of spraying their bedrooms. We also have the use of nets for other purposes that are not really done for that. So maybe this is what I can say in terms of malaria. Thank you very much.
Yeah, thank you, Dr. Corine. That was really an incredible bird's eye view of many different types of interventions and many different ways of exerting against malaria. So thanks for the overview, and we'll come back for more questions. But let me now hand over to the maternal and child health arena, where I invite Dr. Jim Ricca to come on screen and also give us his remarks. Thank you.
Hi. Thanks so much, Laura. And yeah, I've already learned a lot from our other panelists. I just want to kind of give a quick bird's eye view, as Laura says, about maternal child health, or as a lot of people say nowadays, maternal, newborn, and child health. In any case, I'll start first with the types of interventions and implementation modalities that people have tried to scale over the years. And I think these are quite similar to the family planning field, which we'll also be hearing about. So there is a wide diversity, as in the other areas. First, health facility-based interventions are quite common, and much of maternal and newborn care focus, especially over the recent years, has been on facility-based interventions, both at the primary healthcare level as well as at the secondary and tertiary level. Community-based approaches are also quite common in the child health sphere. Over the last couple decades, there have been a number of attempts at scaling up integrated community case management for child illness. In the health system, there, of course, are very important interventions there. Over the last several decades, I have been peripherally involved in some interventions to scale up, for instance, new cotters like midwifery in a number of countries, as well as novel supply chain approaches. And then there's demand generation and other social and behavior change approaches. This is a big focus in family planning and is as well in maternal, newborn, and child health. And I did want to, before moving on to the next subtopic here, I just wanted to particularly point out the idea of policy. And I feel like it needs a special mention. I've seen a number of things written that we're treating the adoption of policy as if it were crossing what I would call the finish line. And I think we can all agree maybe that it is not really crossing the finish line. It's more like crossing the starting line because policies do not get implemented very well or at all in a number of places. And so just having a policy in place, as good as that looks, doesn't really get us anywhere if interventions are actually not getting to clients. Laura and I worked on something in Nigeria with the Federal Ministry of Health on after a 2015 national policy was put in place for chlorhexidine to actually have that be scaled up across a number of states. A couple of points about how we generally work in the field within maternal, newborn, and child health. ExpandNet, the materials that ExpandNet have been a real touchstone, and ExpandNet talks about having a resource team and really emphasizing developing a scale-up plan and then systematic approaches for monitoring and evaluation. This is very important. I wish more people were using it. I think I'm going to contrast this with another approach that has been in place over the last decade or so that was promoted by the chlorhexidine work group at PATH, which was a Gates-funded group. And it took less of a public sector focused approach. It did work on chlorhexidine, which is a commodity for prevention of newborn sepsis. And so it really kind of took this product and market-based kind of approach. It assumed a mixed public and private landscape. There was a lot of emphasis, and is a lot of emphasis on market and product shaping, and also emphasis on the client with formative and behavioral analyses to know what a client is looking to, for. So there are, various approaches there. And I just want to take just a couple of minutes then with this idea of barriers and facilitators. Common barriers, common facilitators, let's start with the positive. Having a multi-partner technical work group, I think this is something that's been really promoted by ExpandNet, and a lot of people have really kind of are all in on that. Having systematic approaches to policy and advocacy. Like I said, it's important, but it's not enough. It gets you to the starting line, so to speak. Real emphasis recently on adaptive management using a mix of quantitative and qualitative information. A couple of barriers that I think are continue to be out there. Having a common understanding about what we mean by scale up when we're not always talking the same language. sometimes a mismatch between what a donor is looking for and a Ministry of Health. And I think a donor, unfortunately, sometimes is looking for quick wins. And I think there's not enough realism about how long it really takes sometimes for scale up to occur. Maybe not sometimes, most of the time. It probably needs at least 3 or more of your average typical 4 to 5 year planning cycles. I still, though, unfortunately see unrealistic things written that think that this can all happen over one or only part of one of a typical project period. And I want to close with one last point here, which is that I think the experience that many of us have had shows that scale up is kind of in a middle ground. It's neither a tightly controlled pilot, nor is it like routine care. And I think a lot of the things that we do to promote scale up have to acknowledge this middle ground in terms of governance and management. It can't really be completely within the kind of routine systems. There probably needs to be some kind of coordinating body. The planning is not just going to go into routine cycles, but it shouldn't probably be project-based either. So what does that look like? Costing and financing and resource mobilization, again, not just in the line item budget, but where does it fit exactly? Where is it in the health information system? And also, where is it in terms of monitoring and evaluation? We talk about learning a lot of times within the kind of scale up and kind of iterative learning, and a lot of the monitoring and evaluation needs to take advantage of that. So I just wanted to bring up those points in closing.
Yeah, great. Thank you so much, Jim, again, for these immensely rich reflections. I like that policy is the starting line, not the finish line, but also many of the other things that you raised about resource teams and the need for special attention to scale up, because it's not the same as routine program implementation. So I think now our moderator has arrived and he caught some of these remarks, not all, but he was definitely studying up for this session. So hopefully, Lester, can I invite you to join us on camera? And we'll do our test right now and see if your mic is working, and enable you to moderate the question and answer with the panelists. Lester, over to you. Thank you. Oops, your microphone. We see you, but we're not hearing you.
Can you hear me now?
Yes, thank you, Lester. Go ahead.
I missed quite a bit of it, so I would not be fair in my questions of jumping in. So why don't you continue? And if I have questions as I listen in further, I'll join.
That sounds good. So
thank you.
So I can moderate the discussion, and then we'll count on you for some reflections just on the parts that you were able to hear, if you can.
Sure.
Great. Okay, so as I said, everybody raised very rich discussion topics that could be taken up, any of them in great detail, but we did develop as a team some key questions that our speakers might address that would illustrate some of the things that people touched on already. So one of the things that everybody talked about to different degrees, but I heard particularly in Charles and Corine's comments, was the fact that the nature of interventions can vary really widely, including even the delivery mechanism, right? So in some cases, we heard about community health workers. In other cases, we heard about facility-based. In other cases, there were strictly community-based interventions. And so we, it's this nature of the intervention and the fact that this really shapes the scaling up approach that I just would like to have people talk about a little bit. So if Charles, maybe you could talk about, which you touched on, the target audience, the beneficiary, the ultimate beneficiary. If you might talk a little bit about how this how this nature of the intervention really shapes how the scaling up process proceeds. Why don't you kick us off, Charles?
Thanks, Laura. And just really enjoyed hearing from Corine and Jim, and thinking through some of the similarities and real differences and things that we can learn from each other. So thank you both. And, you know, as I mentioned, I think one of the interventions that really has dominated the HIV response has been HIV treatment. And if you think about it, it's really, we've gone from sort of the emergency phase to really treating it like a chronic disease. And like any chronic disease, one of the biggest challenges was creating a longitudinal system of management, including patient files. And, you know, initially those were paper. And then as we, in various clinics, moved from hundreds to literally thousands, and then in some clinics, literally tens of thousands of individuals receiving their antiretroviral therapy there. The scale up of both the sort of the clinical and laboratory expertise that was needed was really an essential part of that, as was the peer educators and community outreach that was needed to support long-term adherence. I mean, this is, you know, these are lifelong drugs at this point. And so a lot of that scale up was supported by clinical partners, and it was fairly medicalized, I think, in the beginning. And I think, as I mentioned earlier, that really is starting to change and shift, and we can get more into that in a bit. But as you said, Laura, other, I think, interventions are more shaped in some ways by the beneficiary. And as I mentioned in the introduction, I think a lot of the groups that we worry the most about are those who are highly stigmatized or even criminalized in societies, and that affects everything for them, and especially access to healthcare services. And I think one of the most challenging but important groups that we're struggling to reach are female sex workers, for instance, who, along with their clients in many countries, account for 20, 30, or even 40% or more of the new HIV infections that are taking place. And I think that there have been a lot of, frankly, hand-wringing about how challenging it was to reach individuals who were so highly mobile and often working in around clubs at night. So, you know, public health had to really kind of shift the mindset to think about how best to reach these individuals. And I think the really good news is that some really creative NGOs and governments and all have started to think about reaching them in non-judgmental ways that include outreach by current, former sex workers, and developing these drop-in centers, which are not highly medicalized, and that often provide kind of a warm and embracing environment. And with that kind of social atmosphere, are able then to get people tested and screened for STIs and family planning needs, as well as their HIV prevention needs and treatment in some cases. So I think whereas our medicalized clinics don't often look as outward as we would like, these drop-in centers, I was just visiting some in Malawi a couple of weeks ago, are truly impressive by the amount of knowledge they have about the community in which they're operating. And they understand the hotspots, they understand all the things that are needed to successfully reach these women. I think, so I'd put that out there as kind of a success, if you will, in terms of how we've reached a group of people that were considered extremely hard to reach, and really put a beneficiary-centered focus to our work.
Great, that's a wonderful illustration, and I really appreciate that you touched on both preventative and curative kinds of approaches, because in MNCH and malaria, we also face this balance between interventions that are preventative and some that are curative. And so I think one of the things that we suspect may be true, and from our family planning perspective, is and I'd like to hear Dr. Corine, you to talk about this a little bit, is whether the emphasis on preventive versus curative approach is in some cases easier or more difficult to gather government commitment, community support, acceptability, etc. Because you mentioned that at some point that 86% of malaria deaths are to children under 5, which I can imagine is a real galvanizing circumstance. And so if you would just talk a little bit about how this balance between investing in curative versus investing in preventative plays out in malaria, I think people would be interested.
Yeah, so thank you very much for your question, Laura. So I agree that, of course, we always want to prevent. It's better to prevent than to treat. But as I say, I think there are many components to respond to your question. It's we usually advise country to choose the best mixed intervention, to combine the best malaria intervention based on the cost effectiveness as well as the impact that the malaria intervention can have. And especially for malaria, as you say, for children under 5, it's really a problem. But you will also see that there are many factors like poverty that affects also has an impact on the disease. So for instance, when you look at children from the poorest household are 5 times more likely to be infected by malaria compared to the wealthiest. And when you look at the data, for instance, in terms of children that are being properly treated or diagnosed in Africa, we only have 40% of those children. So the poorest household have also the higher proportion of household income spent on treating malaria. So it's important for us to promote prevention, and at the same time, we also have new intervention like the chemo prevention, where you also give preventive drugs so that the child can be protected from malaria. So, of course, to put a balance, as I said, it's very difficult to decide if you will go for prevention and treatment. But what has shown is for malaria, there is no silver bullet. So it's really important to combine both preventive measures as well as treatment. And of course, as you know, the treatment of malaria, we are currently using artemisinin combination therapy. That also helps to clear the parasites in the blood so that when the mosquito comes to bite someone, it's not going to transmit the disease to another one. So I think those are, this is what I can say here. Thank you.
Great, thank you too. And so let's move to a question about institutionalization. We hope all of our interventions, we hope, will become institutionalized so that they will be sustained over time. But institutionalization is a kind of a long-term process. Like Jim was saying, it can take 3-5-year cycles, so 15 years before systems really fully have capacity to implement, and that can vary widely too. So different initiatives take different kinds of approaches and give different priority to efforts to institutionalize. And so I think that it might be good to hear a little bit about this from a couple different perspectives. At the very beginning, when Charles spoke, he talked about working in a verticalized manner under PEPFAR because it was an emergency and it wasn't like malaria, which has been going on for a long, long time. So maybe we could hear from Jim a little bit, talking about from the maternal and child health perspective, about how projects and initiatives might be working with government, supporting government and other local stakeholders to institutionalize into local systems and institutions. Jim, can you jump on and answer that?
Certainly. Thanks so much, Laura. Yeah, this is something I know you've thought a lot about at ExpandNet, and it's really influenced a lot of people's thinking, and I think really a positive thing. Now, we work a lot, I've worked a lot in kind of the public sector. So we think of institutionalization within the health sector. A lot of times people get locked in right away. And I think actually this isn't necessarily a bad thing. They get locked in right away to the WHO, the World Health Organization, health system building blocks. They're a great way to kind of think systematically through, you know, what are all the things that need to be in place in order for an intervention to work. Is there an information system? Is there a human resource system? Is there a planning and governance system, et cetera? So being able to think about where things stand in each of those systems is a really good way to, I think about whether or not things are getting institutionalized. So that's a great way to think about it. How do we actually do it? That's not quite as easily, it's more easily said than done, as we say a lot of times, right? Because I think again, there's this tension of this middle ground where a lot of the funding for scaling something up comes through temporary funding, through project funding, and there's a lot of pressure in those cases to kind of show results. And the results that people are looking for are a lot of times not the system's results. Unfortunately, what they're really looking for is a spread of the intervention. And so trying to make sure that we're also paying attention to the institutionalization, you know, remains important, and it's not given enough attention a lot of times. But one last point in passing here, I think, is public systems aren't the only places where things can become institutionalized. I think Larry Cooley from MSI likes to say that whether we acknowledge it or not, everything is a public-private partnership. And so there are always going to be aspects, even when we're focusing on the public system, that are coming from the market, a product that might need to be produced and procured, or even if we're working in the market too, there are, you know, things on the public side that need to be in place, regulation, laws and policies and other things of that sort. So I think on the private sector side, getting things institutionalized, so to speak, is really something that's more like trying to make sure that we have a good business plan, that things actually are economically viable, and things that I probably cannot speak as well to as others, because I do, as you know, work on the public side much more. But just one thought there.
Great. Thanks, Jim. That's terrific. Let's take up that financing issue a little bit more. You talked about a good business plan. I think that one of the interesting concepts around resources is, of course, it's critical for scaling up, but it's not a panacea. Sometimes, you know, there might be enough resources, but there isn't enough capacity, and there's all kinds of mismatches there. There's capacity, but not enough resources. So maybe let me pose this question more formally to, let's start with Charles, and maybe Corine, if there's time, you as well. I'd like to ask you to address the role and the amount of influence that external and global donors play in setting priorities for your technical area. You can draw on your experience from countries, from the global arena, just to talk about how the type of donor, the perspective, and the resources that they bring bear influence on how scaling up has proceeded of particular interventions or activities. So Charles, why don't we start with you?
Thanks, Laura. Yeah, I think it's a really interesting question, and I think there is no question that the global success that I think we've had with HIV, TB, malaria, and other areas has been underwritten by like truly historic levels of funding from bilateral donors such as PEPFAR, USAID on TB and malaria, as well as the Global Fund. You know, that has made for that's made so many of the things that we care about in terms of these global responses possible. But I also think that it has meant that these groups obviously have a lot of influence in the way that the scale up was approached, and to this day continue by the way that they allocate funds and the choices they make in terms of where sort of national and subnational priorities lay. That influence is still there, and I think very important. I think what you see is in the multilateral setting, the emphasis, from the early days with the Global Fund being on country coordinating mechanisms that were really multi-sectoral in nature. The intention was, and I think in many cases it was realized, to have sort of country demand-driven applications that really got at where the priorities lay with national and other decision makers and civil society. And that, I think, was complemented by PEPFAR's approach, which, runs through the U.S. missions and is also subject to a lot of input by government, by civil society and others, but was, I think, more target-driven and engaged with a broader array of partners. Now, some have criticized sort of the various approaches. I've always seen them as being kind of a yin and yang of kind of working together to support countries by offering a couple of complementary mechanisms that, in some cases, in the bilateral case, may be able to move faster in some ways to meet a country's needs. In other cases, may get misaligned with where a country wants to go, either maybe over a piece of evidence or a decision about a new intervention. But I think what I want to say now is that we see a huge movement in the HIV field to kind of shift power. And I think that's happening in a lot of fields, and to really think about the power structures that exist, looking for ways to decolonialize, if you will, various elements of the power structures so that you end up with a much more country-driven process by which priorities are established. NSPs, National Strategic Plans, really are kind of the basis for a lot of the funding that takes place. And I think Ambassador Nkengasong, who leads the PEPFAR program now, has very clearly articulated ways in which we can move towards somewhat more regional priority setting through Africa CDC, and which really is operating with heads of state to, I think, exert some really favorable influences on the existing power structures.
That's helpful, Charles. Thank you so much for reflecting back on these decades of your career working in this area, because you can do that so well and watching these transitions. Corine, now maybe we can hear from you, because you had the opportunity to lead these kinds of activities in the malaria domain in Rwanda, and were interacting with donors, and maybe you can sort of tackle that question from the Rwanda government perspective in terms of about donor influence over processes, etc. Over to you.
Yeah, thank you, Laura. So maybe before I go to the country perspective, I also agree, and in the same line with what Charles says, when we look at the funding landscape before, when, for instance, the presidential malaria initiative started, and now you really see that there is localization, there is transfer of capacity, as well as trying to involve and then get local NGOs to implement malaria control intervention, and then of course scale up all the malaria intervention. So as for HIV, we also do have a national strategic plan for malaria, and those national strategic plan, as well as they are also developed in a participatory approach in collaboration with all the stakeholders. So although we feel that maybe the funders or the donors are influencing the priorities as well as specific intervention to scale up, usually it's based on evidence, based on the data that the local context. So it really, for me, for countries that have a strong national strategic plan, usually the funders as well as the donors are supporting the countries based on the country needs and priorities. Of course, this needs to, of course, there is a room of improvement. So in terms of my experience in Rwanda, of course, we used to have a national strategic plan. And it's also quite important to say that most of the innovation as well as the new intervention where, if I take the example of, for instance, the home-based management of fever, it started with 5 NGOs. They were within the core group, and then they started to implement the home-based management of fever, recruiting community health workers within the district where they were implementing the activities, of course, using the NGO, the international NGO staff. And then after we saw the result, we saw the impact, we saw that they were treating more malaria cases, and then we were also seeing that there was a decline of malaria. And most of the small pilot activities, pilot initiative, when you monitor very well, you show the result, usually it's an opportunity for the government, for the Ministry of Health to institutionalize and then to expand it to other districts. Of course, we started with 4 districts, expanded to 8 districts, 9 districts, and then until it became country-wide. So I think that most of the scale up of intervention, it's usually based on the data. When you can show that there is an impact, it's usually chosen and then included within the strategic plan of the country, and then of course implemented. Of course, what is important is usually funders, they usually have the flexibility to implement a new intervention, and then this is how it's scaled up at country level and then institutionalized within the health system or the primary health system. Thank you.
Yes, great. That's very reassuring to hear the processes that malaria has gone through in terms of following government lead and bringing data to bear and helping in facilitate those decision-making processes. So one of the things that everyone has touched on to some degree, some more than others today already, is this relationship between scaling and equity. There's often a tendency to pilot and scale interventions with populations that are easier to reach. However, our perennial question is, how do we reach the most vulnerable during the scaling up process? And I heard both Corine and Charles touch on some of the more vulnerable populations suffering the greatest impact of disease. And so maybe you could draw on your work, and this is a question to all 3 panelists, to draw on your work and your experience in the field. How has the design or the process of scale up addressed issues of equity, particularly reaching the most vulnerable when it implies greater complexity or substantial additional cost? Maybe I should pick who comes first. Jim, we haven't heard from you in a little while, so maybe you could kick us off with an answer to that one.
Thanks, Laura. Yeah, this is a really, really interesting question. I'm really glad that you posed it. I think that this is, the word equity is kind of tossed around a lot. And I think it's not the true implications of equity and achieving equity are not always thought through. I've sometimes seen it on documents where it's kind of one of several goals of a program, that it's going to scale, achieve equity and quality, et cetera. And, that's great. So, but if we really pull out that one word and unpack it, it deserves a huge treatise on its own that, as I look through a plan, a lot of times after it's been mentioned at the beginning, I don't necessarily, see a lot of additional thinking on it. I am encouraged on the other side, though, by recent emphasis, especially within the immunization community. So working in, as I work in maternal, child, and newborn care programming, the immunization community in particular has been working on what they call zero-dose children and approaches for zero-dose children. Zero-dose children in this kind of lingo is those children who have not received even a single dose of any of the routine immunizations. And so they clearly are completely untouched by the health system. What's been encouraging about that is not only is there a lot of emphasis on the new strategies now that can reach zero-dose children, but it's kind of spread to some of the rest of the maternal and child health community, so that people are thinking about, like, well, zero-dose children might be zero-dose for immunizations, but their mothers are probably also zero-dose for antenatal care and for skilled birth attendants and, et cetera. And so now there has been, started to be some thinking about what those strategies might, who are these pockets of unserved people, and what might those strategies be. In any case, it's still early on, and I have not seen truly scaled approaches within that. I just think it's a really nice thing that I've seen recently. Let me just, before closing, because I didn't really talk about how we scale approaches and take account of equity, just touch on that particular topic. Because, like I said before, we glibly sometimes talk about equity, but truly, if we had $1 million or $1 billion or $1 trillion, we could reach the first 80% scaling up and, reach them relatively easily, or we could go to the remaining 20% and probably eat up as much or more of that initial outlay of funding that we have in order to reach them. What do we think most donors and most ministries and most implementing partners and most everybody are likely to want to do? They're likely to reach the first 80 and not think as hard about the last 20. So that has been a problem in general. But one last thing I would say is this: is that within the child health community, even before the zero dose started, I think promising approach that really is an equity-focused approach is to scale up what is called integrated community case management. And most illness care for children has happened in facilities, but integrated community case management is an equity-focused approach to going out and actually finding children who are not coming into facilities, and designing systems through community health workers, through alternative supply chain mechanisms, et cetera, to be able to reach them. So that approach, I think, is a good paradigm because it takes equity into consideration from the beginning, and it's not an afterthought, and it's not just something that, it was paid lip service to.
Very interesting. Thank you, Jim, for sharing that example for everybody. I have one more question before we turn to audience questions. And so I want to pose this one to Charles, but it also came up in Corine's discussions. It relates to the fact that there's always new science coming in. There's new understandings about what works well to address a particular target audience for our interventions, and then we're also finding new efficiencies, and even there's new hard science coming in terms of new treatments, etc. And so I think perhaps the HIV field has really probably been one of the most, biggest experience of this kind of changeability in interventions. And so maybe, Charles, why don't you give us some examples of how your field has adapted and managed to incorporate new science and new learnings and interventions that come along the way during the process of scale up. That may have implications for how things are proceeding. So over to you, Charles, on that one.
Thanks, Laura. Yeah, it's a great question, and we've seen so much evolution both on the, as you say, hard science side of things, as well as I think delivery opportunities for more optimized delivery that's hopefully more and more patient-centered, person-centered, I should say. And we've really been blessed with a rapidly progressing scientific landscape in HIV over the last 30 to 40 years. We now have over 30 drugs in 7 different classes of drugs, and we've been able to, as I was saying earlier, I think generally diffuse that innovation fairly quickly. When I say we, I mean national governments, local advocates, and WHO as a normative body supporting member states to really drive towards using the latest science when it's kind of been shown to be impactful. And one of the things we've done within the HIV field, and I know others do as well, is we use a lot of projection models. And when I was at PEPFAR, we were often able to look at trade-offs between introducing a new drug for antiretroviral therapy that would be, for instance, less toxic. So less people would have to suffer those consequences or stop the medication and switch to another, and perhaps more convenient, but at somewhat higher cost. And we were able to look at the trade-offs in terms of both the cost as well as the benefits that might be accrued. And increasingly, the field has been able to do that across sort of prevention and treatment, and to look at where some of the trade-offs are. And I think that's been very helpful for giving people confidence in kind of saying, okay, I think we really are ready to move on to the next layer of scientific innovation. But I think we've also learned in that process that can't be done in a back room. We have to put kind of potential clients and communities at the center of that decision making, or at least as a central party in it. And a few years back, there was a new drug that came out that had enormous promise for low toxicity, as well as its ability to drive down viral load very, very quickly, which would be important, particularly for pregnant women and other groups. And it was interesting because just as it was being proposed to take to scale, some data came out around neural tube defects if taken by pregnant women. And that then led to a whole series of consultations and delays, and delays really for getting this drug to reproductive age women. And so that led to what was perceived by some kind of an inequity. While the scientific issues were being worked out, there were some fairly sizable protests by women who said that they needed this better drug for its many benefits, and that they should be trusted to take contraception as needed during the time that they were taking the drug. And I think they really hadn't been as much a part of that discussion as they might have been, and so felt the need to protest. And I think that really showed us how innovation needs to be coupled with that consultation at every step. Fortunately, that particular drug was found later not to cause increase in neural tube defects generally, and so was able to be safely used. But I think the community surveys and things that are done now by WHO adds a lot to the guidelines process, particularly when, evidence lacks clarity and where values and preferences are really kind of sometimes a very important consideration for tipping the balance in terms of whether something should be recommended or not. Lastly, I just want to touch on the fact that I think in many cases, the drugs we've got are so good and so non-toxic and generally inexpensive, in some ways it's gotten hard to do better, but except for one thing. And that is really around the frequency and ease of administration. And so as we look for where our field is going for the next round of innovation, we're on the cusp of introducing these long-term injections that would prevent HIV. So a drug that stays in the system for at least 2 months at the levels needed to prevent HIV acquisition. Clinical trial shows that it's far more impactful at reducing new infections because of the adherence ease with getting an injection versus taking 60 days straight of oral medications. So we've learned over the years that it's best to roll these things out in an implementation science learning frame oftentimes, because there are so many potential learnings that while we don't want to slow things down, we want to make sure that people are getting out of the gates with as much information as possible about overcoming some of the delivery challenges and meeting people's values and preferences, both clients and providers. So that's one of the areas that we're grappling with right now, and that is very, very exciting and promising.
Yeah, and great, because you touched on some of the issues from the HIV technical area that address one of the questions from our audience, which I want to pose to the others, which relates to monitoring and evaluation. And thank you, Charles, for touching on that sort of organically in your remarks. The participant, Marie, would like to have you, Jim and Corine, address what we can learn about monitoring and evaluation of scale-up from your experience, which I think is a very important question. Although it's been touched on many ways, it also relates to adaptive management, which some of you have also discussed. So, Corine, would you want to answer a little bit about the M&E from the malaria perspective?
Yeah, thank you, Laura. So in terms of the monitoring and evaluation, particularly for the scaling up intervention, it's important to expand the health information system. So we have seen that in many countries, on top of the health information system, there is new technology, new digitalization of information, for instance, of data that are collected by community health focus, and then expansion of the health information system up to the community, which is also the community health system. The second one is the new technology. So we are seeing countries like Ethiopia, Rwanda, and others that are also doing digitalization of all the malaria control intervention. We have a good example of Benin, where they are using phone to collect and monitor and check if everyone that was supposed to receive the mosquito nets up to the last mile village is receiving, and then data are collected on the phone and then sent to the system. So those are the kinds of monitoring and evaluation that are being done. Try to expand an easy, friendly data tools that can be used both at central level, decentralized, as well as community. And it's really important because when you compare, for instance, there are some countries that you see community health focus are treating 60% of children compared to the existing primary health care, the health center. So it's really important to include those data, and then of course look at the impact of the scale up of those new intervention up to the last mile. Thank you.
Yeah, great. Thank you. And Jim, I know this is an issue of monitoring and evaluation that you've worked on extensively. I often quote you that we don't want to be driving blind in our scale-up processes, and we have to figure out how to prevent that. So, Jim, why don't you just tackle the M&E question a little bit for our audience?
Thanks, Laura. Yeah, actually, I think that's thank you for saying that you quote that. I'm not sure who I heard that from myself, but I'm not the inventor of that quote. So as the kind of driving analogy goes, yeah, one thing, we don't want to drive blind because truly the path is not straight. And so we really need to have some real-time kind of information about potential adjustments that need to be made in the scaling strategy. And that cannot happen only, from evaluations that are going to, and that can't even happen primarily from evaluations, even if they happen relatively frequently. Imagine a place where maybe evaluations happened every year. That's still not even nearly frequently enough to be guiding what's happening. So a first principle with monitoring evaluation is it needs to give quick, rapid kinds of signals about what's working and what's not working. Rapid information a lot of times is not necessarily the most valid information or the most deep information. So how do we balance these considerations? Well, I think as I was saying before, I think that scale is in this middle ground. It should neither be project-based because project-based systems don't tend to be sustainable and scalable. Neither, though, can it be completely routine. If we're talking about scaling up an intervention, clearly this is not yet routine. So as Corine mentioned, it might not necessarily be in the information system yet. We maybe need to advocate that it goes into the information system or pilot in some places, having it be in some districts in the information system before it fully gets put into the information system everywhere, because there is a huge amount of data collection burden within routine information systems already for health workers, and they are all grown at us when we say just one more new intervention with a new indicator. That's very difficult for them sometimes. So just two things quickly. One is there need to be just one, two, or three kinds of quantitative indicators we might look at, to really kind of guide whether or not we're on track. And it probably should not be more than that. But this is not going to give us the deepest information. So we need to complement that with frequent stakeholder consultations to get qualitative information about what's working and what's not. I think some people in the M&E community sometimes feel like, well, if we have those couple of indicators on the dashboard, well, we need to explain what's happening with those indicators with other indicators. And I would say to them, no, we don't. We don't need other indicators. We just need to talk to the people who are implementing and trust that that qualitative information we're getting from them is going to be good enough to guide and to complement those few quantitative indicators we're looking at and give us the information we need to be able to guide the scale up. Otherwise, it just becomes too burdensome.
Thank you, Jim. Those are great insights for our participants. So we only have 4 minutes left, and I'm not sure if Lester would like to give any synthesized reflections, perspective from the family planning field with the few minutes we have. So Lester, if you do want to do that, come off your mic and go ahead. Great, thanks.
Yeah, firstly, I apologize for my technical challenges this morning. I thought this was a fantastic conversation, some great questions from the audience, and I'd really like to hone in on three things that I thought were very powerfully articulated by the speakers. And the first one is about the ambition scale and where does it originate? And in terms of donors wishing to see scale happen and imagining that scale and speed are the same, and therefore, what is the obligation as one thinks about as one scales up of both the importance of the role of donor, but also in terms of educating and informing and shaping their thinking around what does it take and what have we learned about scale. So I think that's a very important part of it, right? A long time ago, a government administrator said to me, if you're going to go for low-hanging fruit, you're going to collect watermelons mainly, right? And it was humorous, but I think it was a moment of learning for me as well at that early stage. The second point I think that's been powerfully stated is the issue of equity. And in different kinds of interventions, one may take a slightly different view, but are we thinking of equity as we think about scale, of who is going to benefit from, who is most vulnerable? And therefore, leads me to the third point, which is one that was mentioned by several of the speakers, the continuous listening, both to more systematically gathered evidence, but listening to communities, listening to the implementers, and using some of those insights that are continuously emerging to adapt and change course to get to sustainable, impactful scale. So I really like the thoughtfulness and the optimism in this panel, the sense that we can do it, we have done it, we've learned a lot, we need to continue learning, and that sense of a community of practice that's evolved so phenomenally, I think is just fantastic to hear. So thanks a lot to the speakers. And I think there were some great questions from the audience as well that we need to recognize in this discussion. So I'll close there, Laura, and hand it over to you.
Great, thank you, Lester. That was really, really wonderful, and appreciate that, and appreciate everybody. I want to extend a huge thank you to our panel for preparing and undertaking this activity with us. It was a leap of faith, and everybody, all the participants spending the last 90 minutes with us, engaging in this comparative analysis. And please be encouraged to keep coming back to the community of practice, to our activities. And we wish you all successful work, all of our panelists, all of our participants, and we look forward to engaging with everybody in this journey of scale-up learning and experience sharing. So stick with us and stay safe as you carry on your critical life-saving work. And thank you all on behalf of the COP and ExpandNet. Bye-bye, everybody.
Bye.